Good morning, everybody. Welcome to Grand Rounds. Today is our second last Grand Rounds of the academic year. Next year will be, unfortunately, somewhat fittingly, Channa Sachs from Massachusetts General Hospital, who's the co-director of the MGH Center for Gun Violence Prevention. And that's one of the social pathologies that's arisen in the context of the past year and a half that we've gone through. And then we'll recess for August and resume in September. Just to mention, the topic of the year, COVID. Unfortunately, the normalization process that we believed we were sort of embarking, sort of locked into, has begun to level off in reverse directions, courtesy of the lack of vaccination rate and the Delta variant. And it's unfortunate because one prolongs the conditions that we've been forced to live under, and our effort or desire to normalize and return to whatever the new normal will be. But in addition, it causes increased potential risk and harm because of the fact that unvaccinated people, which are largely the source of the rising infection rates and also the hospitalization and death rates, are substantial in number. And so in addition to creating an increased need for healthcare services for them, there's also the possibility that they'll serve as a incubator for further mutations and variants that could be either more contagious, more virulent, or not penetrate the immunity of the vaccines. So it's a difficult situation. Locally, we have a high infection rate, a high vaccination rate, but not high enough. It's got to be 100%. And I wish all of the institutional affiliations that we have would mandate it, but all of them can't or won't. So if you haven't gotten vaccinated, I'm making my personal appeal that you do get vaccinated, and we're going to do everything we can to assuage anybody's fears. But in the interim, we have to continue doing what we're doing, which is the social distancing to some extent, the masks inside the institute and the hospital, and also utilizing the rapid testing facility that's available on the first floor of Psychiatric Institute. So please do that. But the main thing is vaccination. I hope this thing will go away soon, but I'm afraid that it probably will be with us for some time longer. So that's about it. Today we have a special Grand Rounds in that it's the product of a initiative that was begun some years ago within the department and spearheaded by Patrice Malone, and then was given the very symbolic and resonant title of June Jackson Christmas Fellowship and Grand Rounds Program. And June Jackson Christmas will be explained to you who she was, but I knew her personally because I'm of that age when she was the commissioner. And it's really a wonderful development to honor her in this way, and also to have a program that's growing and is so unique and beneficial. So without further ado, to introduce that program, I'm going to turn over to Patrice Malone and then Nicole Pacheco, and then our three guest speakers. Patrice?
Thank you so much, Dr. Lieberman. I'm going to share a slide with you all. Give me 1 second. So good morning, everyone. And thank you for joining us for the Dr. June Jackson Christmas Program, Grand Rounds. As Dr. Lieberman said, I am Dr. Patrice Malone. I'm a child and adolescent psychiatrist, and I direct the JJC program. So the Dr. June Jackson Christmas Program was started in 2016 when I was a resident in our Department of Psychiatry, with the aim of encouraging medical students from historically underrepresented racial and ethnic groups in medicine to choose a career in psychiatry by exposing them early on in their medical school training to the breadth of what the profession of psychiatry has to offer. The program began with a 5-week clinical experience during the summer for rising second-year medical students, where they rotate on an inpatient psychiatry unit a community outpatient clinic, the mobile crisis team, CPEP, and the consultation liaison service. In addition, students attend didactics in psychiatry and visit community mental health sites. And soon after the clinical program began, we expanded to include an 8-week research experience for rising second-year medical students during the summer for exposure to behavioral health research. More recently, a current 4th-year resident in our department, Dr. Nicole Pacheco, has spearheaded a 4-week virtual psychiatric outpatient sub-internship for 4th-year medical students from underrepresented racial and ethnic groups. And the first cohort of students for the elective will begin next month. Dr. Jade Avery, a current 3rd-year psychiatry resident, has also joined the JJC team after receiving an APA SAMHSA fellowship. I believe that overall the JJC program is in line with Dr. June Jackson Christmas's professional work as she dedicated her career to mental health and advocating for marginalized communities. Dr. Christmas founded the Harlem Rehabilitation Center, an innovative community-based psychiatric program which trained local Harlem residents to assist psychiatric inpatients with re-entry into society. She worked as the Commissioner of Mental Health and Mental Retardation Services of New York City, and later as a member of Governor Mario Cuomo's Advisory Committee on Black Affairs. Dr. Christmas taught at Columbia University and continues to be active in her community at 97 years young.
Wow.
Isn't that amazing? Traditionally, the Dr. Christmas Grand Rounds has been an event to highlight the change makers in our community that are working to improve access, increase knowledge, and decrease care of the whole person, mind, and body, especially for minoritized populations. And I believe that this year's speakers are in line with that effort. Joining us today are Doctors Ayana Jordan, Utibe Essien, and Eraka P. Dr. Nicole Pacheco will do us the honor of introducing the speakers prior to their presentations. We would also like to remind you that you're welcome to use the Q&A function on your Zoom screen to send in questions for the presenters, as we will have a question and answer period after all the speakers have presented. Thank you again for joining us today, and I will pass it over to Nicole Pacheco.
Hello, everyone, and thank you, Patrice. As she mentioned, I am currently a 4th-year resident here at Columbia today, and I have the wonderful privilege of introducing our 3 speakers today. So our first speaker of the day is Dr. Ayana Jordan, who will be presenting on the important topic of racial and social justice and addiction research. Dr. Ayana Jordan is an addiction psychiatrist and assistant professor at Yale, and she has dedicated her career to creating spaces and opportunities for people of color in academia. I can say from personal experience with working with Dr. Jordan on the American Psychiatric Association board, where she served as the early career psychiatrist trustee, that her presence and excitement around supporting marginalized communities was of enormous value to myself and other residents of color. So thank you so much for that. Dr. Jordan's drive and dedication towards helping individuals reach academic success.
Nicole, can you just turn your volume a little bit? Some of the audience starts having trouble hearing, or maybe speak closer to the computer microphone.
Not a problem. So Dr. Ayana Jordan's drive and dedication towards helping individuals reach academic success and individual wellness is well showcased in her work as the current medical director of recognizing and eliminating disparities in culture-informed healthcare, or more simply known as REACH, which is a program supported by the Federal Substance Abuse and Mental Health Services Administration and the American Academy of Addiction Psychiatry. The program is geared at increasing the number of addiction specialists from racially and ethnic minority populations who obtain training to provide culturally informed addiction treatment. Additionally, Dr. Jordan is now working on an NIH-funded ROI project to provide a computer-based cognitive behavioral program known as CBT4-CBT within the Black church, an evidence-based therapeutic modality shown to be effective in decreasing substance use. She is also the principal investigator of a faith-based recovery program in 8 Black and Latinx churches throughout the state of Connecticut. She also recently published on the use of telepsychiatry during COVID-19 pandemic. Unsurprisingly, given the magnitude and the importance of work that Dr. Ayana Jordan has done, she was recently inducted into the top 40 under 40 society by her undergraduate alma mater, Hampton University. We are so grateful to have you here with us, Dr. Ayana Jordan, to come speak to us. I'll let you take it away. Thank you.
Awesome. I appreciate that amazing introduction, Nicole, and it was a pleasure to serve alongside you at the APA Board of Trustees. Can everyone see my slides? Can everyone hear me?
We can.
Okay, awesome. We're cooking with gas. All right, so I'm going to talk about the importance of racial and social justice in addiction research, especially during the time of COVID, which I call the Rona. And before I get started, I'd like to start how I start all my talks with a land acknowledgement, right? So I'm in New Haven, Connecticut, what we now call Connecticut is the land of 7 indigenous tribes. All land in CT was once Native territory. It is our duty to acknowledge that and realize that many institutions where we work or see patients or conduct research is indeed on Native land. So I'd like to start off by giving thanks. It's also important to understand that land acknowledgements do not exist in the past tense or historical context. Colonialism is a current ongoing process, right? The oppression of others, this dismantling of people's culture is an ongoing process, and we need to be mindful of our present participation. Next, as a Black woman who has existed in predominantly white spaces, it's important for me to lift up the Black Lives Matter movement. Not because other lives don't matter, it's because we need to reinforce Black Lives Matter until our lives are treated like the majority population. So we say, stop killing us, literally by gunning us down in the street, shooting us when we're sleeping, putting your knees on our necks to where we cannot breathe, but also figuratively as an addiction psychiatrist through racist drug policies, right? And so I'd like for us to just pause, because a lot of people have died unnecessarily from the war on drugs, from not having policies that allow us to thrive during the pandemic, right? So we need to just take a pause for 30 seconds and affirm the humanity of people who have died, but definitely people who have died unnecessarily. So give me 30 seconds. I like to close my eyes. I just need you to stop wherever you are for 30 seconds to reflect on the lives lost. Thank you for doing that with me. It never ceases to amaze me how long 30 seconds seems when you're just silent. And I'd like to raise up George Floyd, who was assassinated for over 9 minutes at the hands of the police. I don't have any disclosures and no conflicts of interest. The objectives for the next 12 minutes are these. 1, I'm going to highlight the socio-political factors that contribute to the existence and propagation of health disparities among minoritized populations. I use minoritized, not marginalized, not underrepresented, because globally, racial and ethnic minorities are the majority, but we are made to feel less than, especially in the United States. So I say minoritized. I'm going to highlight the ongoing disparities among minoritized people with substance use disorders, that's SUD with a small s, that have been worsened by COVID-19. But also, just because the United States realized that racism existed last year, understanding that this has been decades, centuries in the making, and we're only seeing it getting worse during COVID-19. Then I'll briefly touch on the funding inequities by race amongst NIH-funded researchers, and then describe some of the innovative research we're doing with the Jordan Wellness Collaborative aimed at addressing these disparities and treating minoritized people with substance use disorders. So let's just look at some of the data. I want to center that in this country, the latest data is that over 90,000 people have died from drug overdoses. So this is more than motor vehicle crashes. This is more than the HIV/AIDS epidemic. So why aren't we doing what we need to do to curb this crisis? Another thing that I want to bring into the consciousness is that it's not just opioids, right? That there are other substances that we need to concentrate that are driving these drug overdose rates. On the x-axis is 2014 up to 2020. On the y-axis is age-adjusted rate per 100,000 residents. This is data from California that we have under review, where we're looking at, here blue is white, yellow is Black or African American, light blue is Latinx, and red is Asian. So you're seeing for all drugs, there was an uptick in the amount of drug overdoses at the height of the pandemic in California, 2020. But then if you look specifically at fentanyl, you see that there's an increase amongst Blacks specifically. If you look at methamphetamine, we're seeing that same trend. Again, with cocaine, there is a steep rise. And so why aren't we talking about other substances, right? Fentanyl, yes, is a main contributor, but what about methamphetamine? What about cocaine? What about the confluence of cocaine and benzodiazepines? How can we be more thoughtful about all of the substances that are being used, and then break it down by race to understand what we're seeing? Here, I'm just showing you an odds ratio where an exposure of having a substance use disorder increases your risk of an outcome, which is in this case in COVID-19. For folks who may not know, odds ratio means like, what is the probability of exposure giving you a particular consequence? Here is COVID-19. So if you have an odds ratio of 1, that just means having a substance use disorder doesn't increase your risk of having COVID-19 than those who don't have a substance use disorder. So if you look at tobacco use disorder, just having a tobacco use disorder, that increases your risk by 8 of getting COVID-19, right? The odds ratio is 8. For opioid use disorder, 10. Cocaine use disorder, 7. So just by having a diagnosis of a substance use disorder, that increases the odds of someone getting COVID-19. If we break it down by race, we see that Black people are more likely to die from having COVID-19 overall. The bars here are blue is for Black people, orange is for white. This is just the rate on the y-axis, the percentage. And if you look at COVID-19 plus all substance use disorders, we see that Black people, again, are more likely to die from COVID-19 in the presence of a substance use disorder. And if we just look like at a recent diagnosis of a substance use disorder in the last year, again, Black people still remain more likely to die as a result. So why is that the case? Give you just a little bit more data, and we'll talk about some of the socio-political reasons that underline. This is a paper that just came out in JAMA in 2021 from Kotry's group, looking at racial and ethnic disparities in unintentional fatal and non-fatal deaths in Philadelphia. On the x-axis is January 2019 to June 2020. The y-axis is overdose numbers. The yellow here is non-Hispanic Black individuals. The dark blue is non-Hispanic white. And then the light blue is Hispanic individuals. So what I'd like to bring your attention to is this part. At the height of the pandemic, April, May, June, you see that there's an increase in fatal overdoses amongst Black people, whereas there's a decrease for white people. That same trend holds true for non-fatal overdoses. Why are we dealing with the land of the free during the height of the pandemic, where Black people are dying from overdoses at the height of the pandemic, where white people are not at the same rates? What is going on? And if you guys don't take anything else from my lecture, I want you to take away that the social determinants of inequity and racism, not race, underline these disparities that we see. So what do I mean by this social determinants of inequity? These are inequities in health and avoidable health inequalities that arise because of the circumstances in which people grow, live, work, and age, I add and pray. The conditions in which people live and die are in turn shaped by political, social, and economic forces. So we spend so much of our time in medicine focusing on this minoritized person, right, with substance use disorder. It can be anybody. We want to help. We say that you have to go to the clinic, you have to take your medication. But what I propose to you, if we ignore the social determinants of inequity, we are not going anywhere. We're moving nowhere fast. We're always going to bump against this iceberg, right? We have to deal with othering, racism, poverty, housing, food insecurity, all of these things that contribute to living healthy or not. So let's talk about the big R, or racism. It's just a system that preferentially advantages others. In the United States, it's usually white people. It disadvantages other people. Usually in the United States, it's racial and ethnic minoritized people. This is the definition from Kamara Jones. She says there are 3 levels of racism: institutionalized racism, where differential access to the goods, services, and opportunities of society are governed based on race. So this happens in housing, education. We'll see for one of the largest funding bodies, NIH. I'm going to give you some of that data. We see examples of personally mediated racism and the differential assumptions about the abilities and motives and intents of others based on race. That's position disrespect, where physicians, no matter what your race, are more likely to spend less time with minoritized people, less likely to go over the risks, benefits, and side effects of an intervention for minoritized people. And then I think what is really tragic is internalized racism, the acceptance by the stigmatized racists of negative messages about your own abilities and intrinsic worth. So when you are saying, why don't minoritized people start substance use disorder treatment? Why aren't they taking care of themselves? Are you thinking more deeply about how is internalized racism, resignation, hopelessness, helplessness leading to some of this decision-making? Also, we have to understand the concept of othering. So if we look at what does it mean to other, just in the Oxford Dictionary, it means to view or treat a person or group of people different or alien to oneself. And what I am going to hope to convince you of is that being left out of the conversation of mainstream America, or this overall form of whiteness, has really led to othering that has negatively affected every facet of the way in which we take care of patients. And one of the ways that we see that is in who is able to conduct research or not. So othering has resulted in limited focus or funding on addiction research that has affected minoritized people, or the treatment of minoritized people with respect to cultural and historical atrocities. Not enough, I don't think, now this is Dr. Jordan's opinion, I don't think enough amends have been made by predominantly white institutions of power to correct this dynamic. And finally, I'm going to show you some data that shows that Black applicants who are more likely to conduct research on minoritized populations, present topics that directly deal with the social determinants of inequity, are less likely to be funded. So let's go back to the Geffen et al. Paper in Science 2011 entitled Race, Ethnicity, and NIH Research Awards. Here they found the blue is for Black, red is Asian, green is Hispanic or Latinx, purple is white, and this is the full sample. Here you can see that Black applicants are 13.2 percentage points and Asians 3.9 percentage points less likely to receive NIH funding compared with white people. So they say, oh, Dr. Jordan, well, what about publications and all this? If you control for everything, their background, their country of origin, previous research awards, publications, Black applicants remain less likely to be funded compared to white people for NIH funding. So unfortunately, 2019, so almost a decade later, we're still seeing this persistent funding gap, excuse me, in NIH research grants to Black scientists. I encourage you all to read the paper by Hope et al. Excuse me. They purport many different reasons of why this has occurred. What was unfortunate to me is that no one in the article mentioned racism contributing to why we see this persistent funding gap. So Carl Hart and I wrote a response and said, how can you talk about the persistent NIH funding gap or Black scientists if you don't mention racism, the disproportionate, unjust, or unfair treatment of persons from a specific racial group, right? And we provide some solutions to correct this funding gap. Unfortunately, this hasn't been implemented in study sections. So we can't think about innovation or access to culturally informed treatment options if we're not funding the very scientists who are more likely to do the work. So in the last few minutes, I'm going to try and leave you with some hope. I don't want you to come around, go feeling hopeless, but you need to know what is the current climate that we're living in. And how can you be a part of the solution? How can you advocate to make sure that these historically white institutions are doing what they need to do? Let's talk about CBPR, community-based participatory research. This is the type of work that we do, the type of research that we conduct for the Jordan Wellness Collaborative, JWC. It's a partnership approach to research that equitably involves community members, key stakeholders for us as Black and Latinx people with substance use disorders, researchers, and others in all aspects of the research process. So we don't already come with the research question if we haven't talked to all those that are involved, right? And so as a result of the CBPR process, we are involved in a lot of projects, but I'd like to talk about the R01 that we have. So thankfully, I'm one of the less than 1% of Black scientists who have an R01. That is abominable. It needs to be much higher, but I'm grateful to NIAAA for giving us the funds. We are actually providing substance use treatment in the church. And I'm just showing you that this truly is a community approach. We have pastors involved. We have the mayor involved. We have 2 people in recovery involved from cocaine and heroin use disorders that are the project. Because we understand that if we are going to provide equitable services or equitable research opportunities, we have to involve everyone. I encourage you to check out that paper. I'm just showing you that we were able to see a decrease in cocaine and cannabis use in just 8 weeks during this trial, okay? So people say, oh, if you provide treatment in the church setting, it's not gonna work. So we were able to show that is not the case. Another project that we're doing is with a co-investigator. She's bad meaning good. She's so fly. Dr. Sherelle Bellamy, who is also in recovery. She's soon to be a full professor at Yale, where we do Imani, which is faith in Swahili. That was the title given to us by the community, Imani Breakthrough, using faith as a way to break through from the strongholds of addiction and substance use disorders. And so what we do in Imani is that we couple a recovery-oriented harm reduction approach with traditional treatment. And this is just showing you that it's a 2-part approach. The first part is based on understanding what is your role in recovery, the 5 R's, roles, responsibilities, relationships, resources, and rights that you need to even want to recover. We understand the weight of personally mediated racism, of internalized racism. So we have to affirm the members that come into the program. We're in 8 different churches throughout the state of Connecticut. We served over 1,000 people. Another thing that we do is we address the social determinants of inequity during those 12 weeks when we're doing the 5 R's. They have recovery coaches that check in with them about how they're doing with their goals. We don't just care if you stop using substances or if you minimize your substance use, but are you connected with the community? Have you been in touch with meaningful relationships? Do you have a job? Do you have housing? These are the things that are our outputs for Imani. And then at the end of the first 6 months, we don't just say, okay, you're done. We say, how can we support you for the next 10 weeks to make sure that you are well? So I want to end with what needs to happen specifically in the area of research in order for us to provide more equitable care. First, we really need to focus on culturally informed collection methods in epidemiological surveys that accurately reflect prevalence rates. So I love when people tell me, oh, these are the drug overdose deaths. Well, I'm like, well, how can we break it down by race? And were we able to make sure that we can target people who experience homelessness, people who are involved in the carceral system where minoritized populations are over-reflected. So that's one. We have to make sure that our survey tools are more culturally informed. Number two, we have to fund and demand as taxpayers that bodies like NIH fund minoritized researchers that are more likely to address culture and understand the importance of culture and accessing treatment. And then finally, we have to directly study how social determinants can improve or exacerbate health outcomes. I am so excited. I always lift up my research mentor, Kathy Carroll, who unexpectedly died last year. I'm carrying on her legacy, and I look forward to hearing from the other panelists. Thank you so much.
Thank you so much, Dr. Jordan. And we're going to ask if everyone can hold their questions till later on in the session. So we're going to go ahead and switch a little bit. And I'm going to be introducing Dr. Utibe R. So he is a health disparities researcher and an assistant professor of medicine at the University of Pittsburgh School of Medicine. And he'll be talking to us today about the social determinants of COVID-19. So Dr. Essien received his MD degree from the Albert Einstein College of Medicine and trained in internal medicine at Massachusetts General Hospital and Harvard Medical School. After residency, he remained at MGH to complete a general internal medicine fellowship while concurrently receiving a master's of public health degree at the Harvard School of Public Health. Dr. Essien's research interest focuses on racial and ethnic health disparities, for which he's received significant grant funding from institutions such as the American Heart Association and the National Research Service Award. In fact, one of his current projects, which focuses on disparate use of novel therapeutics and management of chronic diseases, including atrial fibrillation, within racial and ethnic groups, was recently awarded a 5-year, $1 million Career Development Award from the Department of Veterans Affairs. Dr. Essien has applied his health equity research framework to the COVID-19 pandemic and has rapidly become an expert in examining the disparities that disproportionately affect minority communities with COVID-19. His work has been featured in leading medical journals, including JAMA and the National New England Journal of Medicine. And he's been interviewed by several national outlets, including the New York Times, Washington Post, and NPR. Dr. Essien is a fierce advocate for diversity and equity in medicine, speaking nationally on the topic and co-directing an anti-racism in medicine series for the Clinical Problem Solvers Medical Education podcast. His leadership in advancing health equity led him to be named a 2019 National Minority Quality Forum 40 Under 40 Leaders in Minority Health Awardee, a 2020 30 Leaders Under 40 Transforming Healthcare by Business Insider, and a Rising Star Alumni Award from the Albert Einstein College of Medicine in 2021. We are so excited to have you join us today. Thank you so much, Dr. Essien, and I'll let you take it away.
Thanks so much, Dr. Pacheco. Can you just confirm that my full screen is showing right now?
So we're
just reverse it.
We're seeing your presenter's view, I think. Oh, that's
there you
better. Okay, perfect.
Okay, so I will make sure I got the right screen for y'all. Give me one moment. I want to make sure I can actually read my notes. And so following that brilliant presentation from Dr. Jordan will be challenging, but I'll see what I can do. It's okay, still full screen or notes?
Full screen, no notes now.
So perfect. Thank you so much, everyone. And again, thank you to Dr. Pacheco for that introduction, Dr. Malone, Dr. Lieberman, and the Department of Psychiatry for this invitation. And of course, to my incredible fellow speakers in this session. I will be sure to leave time for the other psychiatrists in the room, who I'm sure you'll all be dying to hear from, and hoping to use my remarks to bring us back to the COVID-19 pandemic and talking about the social determinants of COVID-19. So in, I guess, my 10 minutes or so with you all, I really plan to touch briefly on these three objectives. And again, my role here is to provide that health equity focus and bring us back to towards the Q&A, where I hope we'll be able to have time to touch on a lot of what the three of us are discussing today. So first, describing some of the data related to disparities in COVID-19, which, as Dr. Lieberman mentioned, we're still sadly thinking about even 16 months into the pandemic. Describing, more importantly, the drivers of these disparities, especially the clinical and social, more importantly, the social drivers. And lastly, starting to at least introduce a few strategies for how we can advance health equity far beyond this pandemic and into the future of medicine. So let's jump right into that first objective. I always start every health equity talk with this quote from Dr. Martin Luther King that says, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I think this quote is so important because while it was shared by Dr. King now over 60 years ago or so, unfortunately applies so well today. And I often wonder what a now supposed would-be 92-year-old Dr. King would be thinking about as he reflected on our health system today, a health system that has experienced a burden now of over 34 million infections and 600,000 deaths from COVID-19. And so with those remarks providing the backdrop, it really wasn't a surprise for many of us working in the health equity space when back in April, the COVID-19 race and ethnicity data started to slowly trickle in. And we were exposed to headlines like the ones on your screen here, from Milwaukee to New Orleans, St. Louis to Chicago, where we saw that racial and ethnic minoritized populations, and especially Black Americans, were being infected, hospitalized, and ultimately dying at far higher rates than white Americans from COVID-19. As other national headlines suggested, the issue of disparities was more than a Black and white issue, as Latinx community members, Native American and American Indian community members, and even some subpopulation of Asian populations around the country were experiencing some of the highest rates of COVID-19 around the country. Whether we're looking at the Bronx, where I trained and grew up for almost 2.5 decades, all the way to across the country out in California. And again, those data are panning out just yesterday, where the CDC reported life expectancy lost over 1.5 years over the past year, including 3 years lost in Hispanic and Black populations. So again, many of us know and are familiar with those data that are the driver for this conversation in the first place. And I think that helps us transition to our second objective here, where we'll examine the drivers of the disparities in COVID-19. So I spent the last 16 months, as Dr. Pacheco mentioned, talking, texting, tweeting about the disparities in COVID-19 and have an opportunity to speak around the country about this topic. And I think coming up with this framework in conversations with colleagues and collaborators about how the pandemic has really ramped up our national attention towards the inequities that existed always in our health system, but particularly in this pandemic. And I use that word ramp to represent the 4 steps of this framework, from risk factors to access to care, to missed care, and then thinking about the post-COVID-19 era. And so first, we'll start with risk factors. And we have the clinical risk factors, which are some of the first themes that were coming up when we were first learning about COVID-19. The data were coming out of China and Italy suggesting that the key drivers of infections were hypertension, diabetes, obesity, and chronic pulmonary diseases. And as anyone who practices in the United States unfortunately knows, that racial and ethnic minoritized populations, and especially Black Americans, are overrepresented in the preponderance of these chronic conditions, really experiencing the highest rates of the burden of these medical comorbidities, including 1 in 2 Black Americans holding a diagnosis of hypertension and a 60% higher rate of diabetes in Black Americans compared to white Americans. And so a lot of attention in those early months were focused on these clinical conditions. We've got to take care and manage these, and somehow seem to have forgotten about the social determinants, which Dr. Jordan already touched on in her remarks, and how these social factors play such an important role in not just the development of those chronic conditions, but also individual exposure to the infection. One area where this has been highlighted is in the higher rates of essential workers among minoritized populations. This differential distribution of those who were ultimately deemed essential over the past year led many to ascribe to this mantra of social distancing as a privilege. And those of us who have had the opportunity to work from home, to be business up top and casual below over our Zoom calls for the last 16 months, have certainly experienced lower exposure to COVID-19 than our fellow citizens who had roles in home health care, in nursing homes, in public transportation, food services, et cetera. These roles, again, have been highlighted as being key drivers of increased rates of COVID infection and ultimately of COVID death. Beyond employment status, we have to consider the social environment where our individual patients and communities are residing. As preliminary data and now been published data from all across the country have suggested that the very air we breathe had made certain populations more vulnerable to COVID-19 than others. Unfortunately, due to long-lasting effects of local and federal policies, such as redlining, restrictive covenants, and other discriminatory housing practices from the Jim Crow South all the way to our present day, minoritized populations here in the US continue to reside in communities with the highest rates of pollution, which in turn result in higher rates of chronic lung diseases, like we're putting folks at risk of COVID-19, but again, of course, further place them in just higher exposure to the infection as well. And so again, these were the social factors that weren't necessarily being talked about or discussed early in the pandemic, but were so critical to the disparities that we're seeing. As we move on to the next step in the framework, we look at this access to care aspect. And here, for the last several decades, the issue of access to care has revolved around insurance. Despite many policy advances, including the Affordable Care Act, we know that up to 40 million Americans today remain uninsured, a large majority of whom are from minoritized populations, as this figure from the Kaiser Family Foundation suggests. That doesn't only affect the individual's access to mental health services, as you all know, but addresses some of these challenges around preventive care. The first thing that public health officials were encouraging their patients to do was, ask your doctor about your symptoms. Well, we can only imagine what that has looked like if you don't have insurance or a regular physician to engage with. And since Dr. Jordan shouted out Dr. Kamara Jones, I also have to do the same, as she was one of the first to suggest that the COVID-19 pandemic exposed those who were not just overexposed, but also underprotected from the pandemic. And so again, we're moving along on our framework to think about this aspect of missed care. And here, I'd like to point to the concern that was raised pretty early in the pandemic. The New York Times had back in May or so of last year, this article that suggested, where have all the heart attacks gone? As folks wondered where those kind of classic bread and butter cases that we took care of in our internship or in our medical school training, from alcohol use disorder or to withdrawal all the way to COPD and rule out chest pain, seemed to not be showing up to the hospital. And those kind of suggestions bore out in the data published later on this year, where we saw that nearly 1.5 Black Americans and up to 1.3 Hispanic individuals were more likely to develop cardiac arrest and cerebral vascular accidents or strokes over the time of the pandemic compared to their white counterparts. So individuals were literally missing out on care throughout the pandemic, non-COVID related care. This concern is not just pertinent to acute care, but also as we're considering access to preventive care, access to mental health services, and how our patients were encouraged to engage with us through a virtual platform over the last 1.5 years. As quickly as workplaces and schools shuttered their doors and transitioned to video conferencing, so too did our doctors' offices, leaving so many community members without access to healthcare, not just because of insurance, as I mentioned, but having to rely on limited broadband, on difficult and challenging internet capabilities, and using that same cell phone that a parent was asking their 3 children to do their homework on to also be able to engage with their healthcare provider. And so this digital divide, as it's been referred to, again, goes beyond just being able to speak to your doctor on a video screen. But as you scroll through the apps in the App Store and in Google Play, wondering, well, who has the language capability to actually be able to use these apps that are where patients are being asked to? Here in Pittsburgh, although we don't have the same Spanish-speaking population that you all work with in New York, we definitely have Spanish-speaking patients who literally couldn't access the My UPMC app because it was not in the language that they were able to engage with. And again, this is such a critical area as we think about this issue of missed care. And so in this last step of the framework, we think about the post-COVID-19 era, and that really brings us to the meat of thinking about the social determinants of health, how these places we live, work, and play have always influenced our health and health outcomes, but again, have particularly come to the forefront during the COVID-19 pandemic. When we think about jobs, for example, we think about the historic unemployment that has taken place over the last year and a half, with tens of millions of Americans losing their jobs since March of last year, which we know doesn't just have a downstream effect on whether individuals had the ability to pay their bills last year or to afford their rent, but far down the line, higher rates of depression, of anxiety, higher rates of cardiovascular disease, and other conditions that we take care of every single day in our clinical spaces, being related to challenges around income, challenges around employment. And of course, we know how intricately connected insurance is to employment in our country and to the ability to gain healthcare. The other brief social determinant I'll touch on is this challenge of food insecurity. And we see millions of Americans every day who continue to experience challenges around access to food, and how food is wealth, it was health rather, in our country. And it's such a big driver of the medical comorbidities we see every day on the internal medicine side, but also I imagine some of the same conditions that you all take care of in your practice as well. So that brings us finally to this third objective of my remarks, thinking about strategies to reduce disparities in COVID-19. And I'll just kind of flash these on to the screen because I think that these can really make up the conversation that we'll have in the Q&A, and also touch on some of the areas that Dr. Jordan mentioned as well. How we need to enhance our ability to collect data around race and ethnicity. And we shouldn't be wondering whether or not there are disparities in vaccination a year and a half into the pandemic. How we need to, again, expand access to healthcare, and whether that is a universal healthcare program or other framing that we are currently thinking about in our policy spaces, we have to do this right now. Thinking again about equitable access to testing, tracing back in the peak of the pandemic and treatment, but also now as we're sadly starting to see some of those numbers rise. I won't touch on this challenges around racism and discrimination, as Dr. Jordan did such a wonderful job. But of course, I think we're all going to suggest that as an area that our health system needs to address. And lastly, engaging and elevating that community engagement. And I love that Dr. Jordan is doing that just specifically in her research. And I think that as health systems, we can do far more than just putting another clinic in the community, just going out and ask them to partner with us in our research, but actually serving as anchor institutions where we hire from the community, we work with the community to make sure that their needs are being met. And so I'll close with this quote of hope from our colleagues back in June that mentioned the response to the pandemic has made at least one thing clear: a systemic change can in fact happen overnight. And with that, thank you all for your attention. Look forward to hearing from Dr. Bath.
Thank you so much, Dr. Essien, for your presentation. So we're going to go ahead and flip over to our last speaker. So Dr. Eraka P is an associate professor of psychiatry and biobehavioral sciences at the University of California at Los Angeles. She is the vice chair of equity, diversity, and inclusion, as well as the director of child forensic services. Dr. Bass specializes in diagnostic, assessment, and forensic consultation with adolescents, with an emphasis on high-risk youth, including those with history of trauma, juvenile delinquency, and foster care placement. She recently published on a partnership between LA County to address COVID-19 for young people and families in under-resourced communities. And today she will be presenting on the topic of youth perspectives on healthcare access during COVID-19. And I'll let you take it away. Thank you so much, Dr. Beth.
Thank you so much. And can you guys all hear me okay?
We can hear you and see your slides.
Perfect. And you don't see my janky notes, correct? You just see the perfect presenter view.
Yeah, we see the beautiful slides.
Okay, great. So good morning, everyone. I'm really grateful to be in this space and following these class acts, Dr. Essien and Jordan. And I'm going to be echoing more of the same and really appreciate the RAMP framework, because I work primarily with youth who are justice involved and in the child welfare and foster care system. And so a lot of that framework and structural racism helps us really think about how they've not been able to access care. And so one of the things we, decided to do as we've been doing ongoing research with these youth and their community partners is to start thinking about how COVID has really impacted their healthcare access. So I'm going to talk a little bit today about that and also just some findings, research findings on this topic. Okay, these are my disclosures in terms of my funding. And I also like to open my talks with a positionality statement to reflect on, who I am and why I'm doing this work and what sort of personal biases that I bring. So my personal conflicts of interest are really being a Black, cis, hetero, mother, female, married to a white guy, good trouble champion, and daughter of 2 Black physician activists. And I also want us to think about, the framework of intersectionalism. This is so critical as we think about youth who are system connected, because as we know, there's no single issue struggle, right? So many of these youth who are racialized and minoritized are often intersecting in systems of care like justice and child welfare that are structured by inequity. A few words about my lab. We're the UCLA Commercial Sexual Exploitation Research Group, and our goal really is to conduct community-driven research to reduce substance use, mental health, and reproductive inequities. And what we do is we partner with lived experience experts, survivor leaders, and local service providers, including the Department of Probation and Department of Child Welfare, to really co-develop meaningful interventions for these youth. One of our main partners is LA REP, which stands for LA Reproductive Health Equity Project. And their goal is to really, use a reproductive justice framework to significantly reduce inequitable reproductive health outcomes. So Sandra Schulman really said it well, that we are living in a racism pandemic, and the real pandemic is racism. I mean, that's what we've seen, and that's really been, a public health issue. And really, Kamara Jones kicked it off many moons ago when she pushed the CDC to adopt a campaign against racism. But thinking about different populations and intersectional risk, certain groups are overexposed and underprotected, as Dr. Essien said. And so the youth that I work with who are constantly, I'd say, experiencing gaps in treatment even before the pandemic, it's important to think about how the layering of the pandemic has actually potentiated risk. So our project objectives were to use a community-based participatory approach, partnering not only with LA REP and National Center for Youth Law, but also a youth advisory board. And we wanted to really just start having conversations with youth and get a sense of how they were navigating, working with justice involved in child welfare youth as a researcher and also just as a practitioner in the court system. I know that at best care is fragmented, and the digital shift and pivot that people who were worried were able to, many were able to adjust pretty smoothly. That was not necessarily the case. And so we wanted to sort of explore and try to get solutions generated from youth. We also wanted to talk with youth around their perspectives on their system involvement that's happening during the racial uprisings after the murder of George Floyd. And, people seemed last summer to really, realize that racism was existing. And so that was very much top of mind and part of many conversations, and youth were definitely leaders in that. So we wanted to hear their reflections at this time. Just a few slides to think about, like, what are the demographics of race and ethnicity in terms of who's in LA County's foster care. And this slide really highlights the disproportionality and the color of child welfare and foster care in Los Angeles. And these are all due to, structural racism. So Black youth are overrepresented by 4 times to their rates in the general LA population. Latino youth are also proportionally represented in foster care, but their numbers are high. So it's disproportionately a Black and brown child welfare system. And this is, I would say, similar patterns across the country. However, Black youth predominate. And really sort of thinking about what we do know about youth mental health during COVID. We know that, in some studies, basically researchers have been observing major themes that, youth are living in the ecosystems of their families who are experiencing, particularly BIPOC youth, worsening socioeconomic challenges. And so this is sort of, these challenges include disruption of employment, which puts them at risk for losing housing and other types of stability, food insecurity. In terms of other factors of youth mental health, we have to think about intergenerational trauma, right? And so many of these youth who are living in these communities that are already negatively impacted are experiencing, trauma from their parents who are, really struggling across various domains. And thinking about this also in the setting of the medical betrayal, because many of these families are not only not being able to access testing or care, but they're also like overexposed to the types of work that put them higher at risk for COVID. And I know that Dr. Essien talked about sort of structural determinants of health. So I'm going to move forward a few of these slides. So for child welfare, one of the things that we've noticed is that there's actually been a decline in reporting cases of child maltreatment. And I think as caseworkers and systems were really trying to adapt to social distancing requirements, the social distancing to marginalized and minoritized populations from systems increased, right? And so there was less contact, which on some levels could be seen as a good thing. But remember, these systems are structured to actually provide resources and services. So many minoritized youth, their pathway to accessing mental health is through child welfare. And so the stressors of the pandemic actually increased that divide. And again, this slide really shows that the amount of reports to the child welfare system really decreased. And so families were very isolated. And if we think about that coupled with the reactionary nature of the system, this really deprived agencies of the tools to investigate and support children who were victims of maltreatment. And so emerging forward is thinking about how we can rebuild, a child welfare system that really recognizes and address risk factors that lead to child maltreatment and support families. Rise in unemployment is a risk for child maltreatment, and rise in unemployment, it was directly tied to the job insecurity that people experienced during COVID, and no more that happened mostly for Black and Latinx families. And so in terms of thinking about how do we address racial and socioeconomic inequities, really where are healthcare providers in this? And so we are really critical in terms of screening and developing access points to refer families to support. But we really often, there's gaps in terms of funding, particularly for early childhood program, child welfare initiatives. And as Dr. Jordan pointed out, just research that really interrogates and dismantles some of the racism that persists, allows these situations to persist. One last study I'll go before I talk about what the youth told us was there's a study that looked at sexual minority youth of color during COVID-19, and they really wanted to sort of think about structural and identity related barriers to care, and really looking at how shortage of providers, racism, homophobia, and just general inequality impacted them. And, essentially, state level mental health provider shortage was a predictor in terms of their accessing mental health care, and that matters. So a lot of, systems of care, particularly community systems, were overburdened and not able to sort of be responsive in real time to the needs. And I know just personally working in juvenile justice and being a consultant to the court system really didn't have adequate, telehealth services. So at best, at times they used telephones, which were, not proper. They shut down visitation. And so a lot of these previous existing gaps between treatment need and receipt really became amplified. So in terms of the work that we did with youth, we really wanted to host youth listening sessions. And our goal was to have two, one on health and access, and the other on race and systems involvement. So we had several preparation meetings with our youth advisory board, with Nickel National Youth Center for Law and LA Rep, and we co-developed 11 questions around themes of COVID-19 and racial uprising. And so these were some of the questions that we developed specific to COVID. We really wanted to know, prior to the pandemic, were they accessing services and how often? And how did the variability of services change during quarantine and social distancing? What were their challenges in navigating, if any? And what services did they want? In many ways, the pandemic increased isolation for youth, particularly transition age youth who we were working with. And it increased isolation due to the reliance on technology, which many of these youth don't have adequate technology. And so also wanting to know, what were gaps in communication, if any, between their providers, mentors, and advocates, and how did technology impact their ability to access healthcare services? And then with regards to listening sessions around racial climate, how were they feeling around Black Lives Matter and how that impacted their own sort of personal navigation to the systems? Because youth who are in child welfare and juvenile justice really do have a great amount of racial literacy. They're experiencing the acute dehumanization of these systems, but rarely do people try to, especially researchers and academicians, try to center their perspectives. And so we wanted to sort of get a pulse and a touch point from them while this was going on. And so some of the emergent themes that came across are really, disruptions in continuity of care, really what is the role of their mentors? They experience inconsistency in services and communication, accessibility limitations, and really, realization, or not new realization, but ongoing recognition around racist systems. So with regards to continuity of care, I'm just going to share some quotes from the youth that they shared, but COVID affected how our needs are being met. I don't think they realize that we get attached to our therapists, and if we're switching therapists constantly, it's not really helping. You shared that, particularly who were in community systems, that there was a lot of caregiver turnover. Everybody had to, the pandemic was equal opportunity, and that everyone was adjusting their work processes and procedures. And so there was a lot of turnover in some community systems, and not everyone was able to work in the same way, right? Because they were navigating their own, personal challenges of raising children at the same time that they're working. And so there's a lot of therapy turnover, and youth who are system connected really experience this greatly. So they notice that there is just less frequency of services in the juvenile halls. For example, youth who would have weekly to 3 times a week therapy may have them have therapy contact just once a month. And so this was one of the challenges, and also this sort of abrupt shift and termination of services. And so this is really problematic, particularly for youth who are in the child welfare system, because having stable attachments is really key, and having to start over and over again can be really harmful. And so they talked about this sort of disjointed, fragmented care where they would just sort of lose a provider. And they said, we as foster youth deserve a warm handoff to another resource. In terms of mentor role and responsibility, they really highlighted how COVID has affected how their needs are being met, that they don't realize that that youth get attached to their therapist. I think this must be a duplicate slide. Okay. Inconsistency in communication. So one youth spoke about, going to Planned Parenthood, but that, they would show up and then the doctor wouldn't be there. Not having access to the health center and not being able to access documents that they need to upload, or having to jump through hoops. They found that people just stopped communicating, and that COVID has been a roller coaster in all of their life. Also accessibility limitations. So this really speaks again to the digital divide and digital disparities, and what some people have called digital redlining, right? But one youth, it was really heartbreaking, but she was a transition age youth living in a van and said, look, I don't always have electricity. And people don't really interrogate that. They don't think about the sort of transition that some youth may be homeless and may not have the type of access. And so there's not that level of accountability around these sort of technology challenges. Other youth who are relying on using their phone because they do have mobile technologies, but may not have iPads and computers. But they're having connectivity issues due to broadband challenges. And in terms of racist system and perspectives, youth are saying, I feel like the system was based off a racist system because people are the target of these particular entities. And I just think it's always going to be a thing, just learning how to combat and seeing things from our point of view. Another youth spoke about, it's so blatantly obvious that the medical community disregards our comfort and thinks that we can take a lot more stress and pain than we actually can. I grew up seeing how doctors treat my family and how they treat me, and how they have a distrustful relationship with medical personnel. And this other youth really sort of, felt that their eyes were open and really wanted to work more broadly at combating racism. So in conclusion, the youth helped us, come up with some of these conclusions, but basically digital divide impacts accessibility and delivery of mental health services. And these really need to be addressed. And this includes screening around technology access and structural factors that can impact participation. These include home broadband, age of the devices that they have, right? Their digital literacy and that of their families, living arrangements, and privacy to even be able to have the space to do that. And one of these ways is to really think about cross-system collaboration between health systems, child welfare, community organizations, and local government. And last, that healthcare systems and providers should really be communicating their limitations and strain, because fragmentation became worse after the pandemic, and that structural interventions are really key, that we really need to increase the density of providers and community systems of care, and also have an emphasis on linguistic alignment. And both thinking structurally is that not only do we need to think about care, but we need to link youth to resources to address food and housing insecurity.
Thank you so much, Dr. Bath, and really thank you to all of our presenters for these informative and powerful presentations. We certainly appreciate you. We're going to move on to our Q&A. I want to remind folks that we do have a Q&A function on the Zoom, and I do see questions coming in. So please continue to send your questions in. I also want to acknowledge that we have invited Dr. Jean Marie Bradford to join the discussion. Dr. Bradford is our inaugural director of the Office of Equity, Diversity, and Inclusion in our psychiatry department. Welcome, Dr. Bradford. We certainly would like to hear your comments as we're discussing and answering the questions. You're doing such powerful work in our department, and we just really appreciate all the efforts that you are putting forward. So, so one thing to start off with is that folks are asking for the slides. I don't know if presenters feel comfortable with maybe passing the slides on to us. You can certainly send them to me. They really enjoyed the presentations and I think would like to refer back to the slides. People also asked about the recording, and the Grand Rounds recordings are usually posted on the website. So you can certainly go there to refer to the presentation if you'd like to watch it again. You liked it just that much. I certainly have a number of questions. I wonder if, you know, just since Dr. Bradford is just joining our fold, we would love to hear from you, your thoughts or comments or questions for the presenters.
Hi, everyone. Thank you so much. First of all, I'd just like to thank you for Dr. Malone and Dr. Nicole Pacheco. Just really thank you for organizing this and putting this together, and to our three outstanding speakers, two of whom I know well. I really am delighted to have you all here, and thank you so much for your really timely and outstanding comments today. I really hope that our interns are listening to this Grand Rounds, because Dr. Jordan, some of your comments about the social determinants of health were very relevant to what we had just presented and the kind of series in which we're doing. We just launched a new health equity and justice curriculum that's longitudinal. And so we started with our interns, and so I'm really happy to, you know, hear your presentation. It really dovetails into nicely what we're working on with the interns, so hopefully they're listening. And also, Dr. Essien, I really appreciated the STEP framework for thinking about and conceptualizing the COVID, you know, crisis and factors that are driving that. And I think that that's something I'd like to incorporate as well. So thank you for sharing that. And Dr. Bath, I work mostly with older adolescents and mostly adults, really, but really the same kinds of things that you've been experiencing with your youth, you know, is what we're seeing with our adults too. Just difficulty in access and engaging care, transitions, and we even went so far as to apply to grants to get technology to deliver technology directly to our patients so that they could access services with us, because otherwise it was just, there was great, you know, they would relax a lot of the telepsychiatry provision so we could conduct sessions by phone, but that's just not always as good as other methods. So we even went so far as that. So I really just wanted to just comment and just say, I really appreciate everyone here, and thank you for doing this and coming.
Thank you for your comments, Dr. Bradford. I think that segues kind of the comments that you made at the end segues a little bit into a question that was asked by an audience member. So I'll throw this out to everyone. So they're wondering if you've seen benefits of virtual learning and virtual treatment in minoritized communities. So are you seeing, for example, increased engagement and increased access for psychiatric and medical treatment of patients, especially in marginalized communities?
I'll just start really quickly. And I think one of the things that Dr. Bath talked about so brilliantly is the technological divide, right? Or the technological redlining. I think there is definitely opportunities, and we've been able to, because of the pandemic, we had to, right? We couldn't do the Imani program. We didn't have, or the IRB, we didn't have permission to have people gather in the churches because it wasn't safe, right? So we had to shift, but the reality is the population of interest didn't have access to computers at home. Most Black adults, this is published in the Pew Research data, don't have access to the internet through personal computers at home. So that meant we had to purchase smartphones for everybody. So if you think about that, that's 1,000 people that we had to have money to be able to get them smartphones, but also with the smartphones, you need access to the internet, right? So yes, we're able to take care of that population, still have them engaged, but there had to be resources put into making sure that they had just not only the technology, but also the literacy. What do you do with someone who has never had to navigate a smartphone, who has no idea how to do it? There has to be an opportunity for learning. So we have to start getting real. And how can we live in quote unquote the wealthiest country in the world and not have internet for all? I mean, these are the things that we have to start talking about. So absolutely, it could be, and it can be, and we've been able to do that in Imani Breakthrough, but we have to have the resources, the human capital to show people, but also we just got to buy this stuff. So
I want to echo Dr. Jordan around the just sort of making digital broadband a basic utility. It needs to be treated like electricity, water. And I know the Obama administration had put forth legislation a while back to do that, but that's really critically important. And then I would say, just my experience, we were able, surprisingly, since I do work with youth who have histories of commercial sexual exploitation, and they, in general, because of their exploitation, can be itinerant, running away, etc. And so sometimes it can be hard to have focus groups and listening sessions. And I noticed that it was easier in the pandemic to do so, that we had better attendance. They kept wanting to come back rather than everyone going to a brick and mortar type of place. And, they were able to do it in real time. And so that was really encouraging. And, and they logged in with their phones. So they weren't using laptops and iPads, but they were really using their phones. And so I think what Dr. Jordan's saying about, giving people the smartphones if they don't have them, but also they need the data plan so that they can participate in the array of services. A lot of digital health interventions rely on apps or technology that takes a lot of bandwidth. So you need the data plan, right? You don't want to be worried about if you're doing ecologic momentary assessment, someone being worried about sending a text because they don't have enough data. So we need to sort of think about ways to optimize, structurally optimize engagement and participation.
Yeah, I would agree with all the above. I don't think it's an accident that we all had some form of digital equity in our remarks, and I think that that's the future.
We have another question about community-based participatory research and actually using that to our benefit when it comes to vaccine hesitancy in certain minoritized or marginalized populations. And I wonder if you guys have thoughts about that, or how we can, as providers, help those communities, our communities, to become more educated, more comfortable with the vaccine.
I was going to defer to Dr. Jordan, since she is our resident expert in CVPR with that R01 funding, in case we forgot, less than 1% of Black women. But I think the time for having CVPR be a part of our vaccine conversation was 18 months ago, right? It's not now that the vaccines are out and flowing. It was back when we were just thinking about, hey, later this year, we're going to have a new vaccine and a new therapy. It's the same issue that we see, whether we're thinking about new cardiac medications that I work with, or probably some of the psychiatric meds that you all use every day. And so I think these are conversations that we had to have a long time ago, and now it's moving beyond the research to actually engaging a community. And again, I'd love to hear Dr. Jordan's thoughts there as well.
Yeah, no, I appreciate you. I mean, the bottom line is that when we're really thinking about CBPR, it's an equitable approach. At its core, it's a flat team. And what I mean by that is everyone's opinion counts the same. So the researcher, the principal investigator, the person who has the community informed expertise, the population of interest, that representative, everyone is at the table and really thinks creatively about how to design an intervention or design an experiment or create methods that are going to represent all of the folks that are at the table. And so we've really fell down, we continue to fall down because CBPR methodology is not funded at equitable rates, period. And so yeah, of course, that would be a tool to approach vaccine hesitancy. One of the things that I'm really proud about is, you know, many of my friends and family members just refused to take the vaccine. They said they didn't have enough information. They were nervous. I get it. So thinking about CBPR and being a CBPR researcher, I planned a party. It was called Fully Vaccinated During the Time of Rona. This is the bands. Everybody had to say, for you, for me, for all. COVID vaccinated. 22 people got vaccinated to come to the party. No, they wanted to see me. They wanted to see others. People have not seen each other, but they knew they had to upload their vaccine card to get to the party. So how can we use that? I use that as an example to start to think creatively, right, about the people that we love. But if you're not engaged with the people and you don't have you're not in a relationship with the people, how can you care for them? So yeah, CBPR is a tool, right? Another way though is structural competency. Want to shout out to Helena Hansen, #CiteBlackWomen, and Jonathan Metzel, who started structural competency as a way to bring about equity. So how can we really form partnerships with nonprofit organizations, community members, folks who are already doing this work in order to think about how can we collaborate to bring about equitable outcomes. So I think that's when traditional academic programs really fall down, and it's not seen as I don't know, sexy, or it's not as, you know, reputable to do that work when you're involved in these things. But that's really the way towards equity. And so yeah.
And I wanted to just like piggyback on that because we all mentioned Dr. Kamara Jones. And when she talks about structural racism, she asks us to ask, like, is racism operating here? And who's in the room and who's not here, right? And so are there people missing from being able to co-create the solutions that are going to impact them? Or using the FUBU, you know, for us, by us method. A lot of times we're not really centering the voices of people with lived experience who really need to be, you know, at the table co-creating these solutions.
Can I just interject a question, Patrice? Comes from Betsy Fiddleson. As this is Black Maternal Mental Health Week, I'd like to comment that maternal health is at the intersection of all the systemic disparities that the speakers have addressed, and mental health is a critical factor for risk of maternal death. Black women are 4 times more likely to die in pregnancy and postpartum in the US. So my question is, how should we be thinking about our systems with regard to maternal health?
I mean, I want to get Dr. Essien in here as the internist in the room. But again, just going back to a partnership approach. Where are we able to bring more Black women in the room? If we don't have systems that lead to more Black physicians, Black female physicians, that's one issue. But how can we bring in doulas? How can we bring in family members into the birthing process? Why do we have these constructs where, like, only one person is there, only this person is allowed. How can we educate folks to be more informed so that they can be included in the process? This is what we need to start thinking of. How can we think about non-traditional modes of care that are more, that might be more acceptable to Black women, that might take care of Black women more than our traditional settings. I think until we're being very honest about how toxic the healthcare system can be for Black people, people don't want to talk about that. Healthcare is racist, period. Healthcare institutions are racist. So until we're able to figure that out, are there alternative methods where we can shift, where OBGYNs are able to partner with non-traditional clinics or non-traditional places of care?
Utibe, you want to jump in?
Please.
Sure. Thank you, Dr. Jordan, for sharing out the internal med form. And again, I think working together across specialties is critical here, because that really addresses the point of the question, which is the systemic disparities. It's not the individual patient in the room because of their personal risk factors alone, because of their personal behaviors, because of their lack of engagement in the health system that resulted in these maternal mental health or physical health disparities. It really is the structural and systemic issues. And so I think we have a chance to work together as various specialists to really address these. And again, thinking way beyond medical providers, like Dr. Jordan mentioned, to our colleagues, community members in our spaces that can really help us get more specifically at what the needs of our Black women to that specific point are.
I'm going to interject because we're a minute over time, and I definitely want to be respectful of everyone's time. But I have to say that I don't know about, one of the issues with kind of the webinar format is you don't get to see the audience's kind of reactions on their faces. But I would say that I am probably speaking for everyone, including those in the audience, in saying that we've learned so much today. It was a really powerful discussion, and also the presentations were really amazing. I think that, just to kind of sum everything up regarding, especially the JJC kind of platform, these are the kind of events that we need to have. We all need to be doing our part in whatever way that we can. And so I certainly respect everything that you all are doing. Your research is just phenomenal. But then in addition to that, you're in the community doing the work, and we need kind of an all hands on deck approach. So I just want to say thank you, and we really appreciate you. I guess till next year for the next JJC Grand Rounds, wishing everyone a happy and healthy day.